My name is Katie Dell. I'm an occupational therapist and the clinical specialist for Bionic, and I'm located in Denver, Colorado. Today, I'm joined by Sheree Wallace from Bionic Labs, located in Dallas, Texas, and Sue Bodziak in Tallahassee, Florida. I would now like to introduce Sheree and Sue, who will be our presenters today.
Thanks, Kate. So welcome to the third program in our series. If you've participated in the first two, you've seen how we developed our devices and the research that has gone into the process of determining how to best use them, and then how to specifically address the problem of spasticity using robotics in rehabilitation. During this session, I would like to introduce you to the InMotion Reporting System, beginning with the InMotion EVAL, and then talking about types of treatment protocols that can be used to address specific deficits using a patient example. We will follow that with a discussion with Sue Bodziak from Tallahassee Memorial in Tallahassee, Florida, who will lead us through how she utilizes the reporting capabilities of the system to drive therapy within her facility. On the screen, you can see our course description and objectives. So let's run through the process of using the reporting system with an example patient. Your patient has had a stroke and has right arm weakness and hypotonicity. You have the InMotion ARM to use for rehabilitation, but where do you start? The InMotion EVAL will help assess the patient's baseline impairment, along with all the other evaluation techniques you regularly use. The results will help determine what treatment modes will work best for your patient, both with the robotic system and with traditional therapy. The patient progress will show as you progress through the treatment, and changes in the InMotion metrics can be used to gauge success and to show that progress both to the patient and to payers. So we'll take a look at the components of the evaluation to start with. The first task performed as part of the evaluation is the circle test. This is performed by having the patient draw as large a circle as possible from two different points along the circle in both the clockwise and counterclockwise directions. This is done to analyze the patient's active range of motion and coordination. In our patient's case, we see the following graphic and metrics from the report. So you can see by the graphic, we have uncoordinated movement, which registers as this kind of scribbling motion showing up in the graphics of the circle test. Possible causes of this could be weakness, lack of coordination, limited range of motion out of flexor synergy, or even pain. The metrics show limitations in circle size and shape as compared to healthy individuals on the same task, which is reflected here in what we call the percent of expected performance, or percent EP. In this case, the patient was able to complete all repetitions of the test, showing good effort and concentration, which can also be monitored over the course of treatment. The next activity in the evaluation is to have the patient perform a point-to-point motion around a center point of a circle. The purpose of this activity is to analyze specific motions made by the shoulder and elbow to determine active range of motion and movement coordination out of synergy pattern into multiple planes around the circle. When the activity is opened, the arm robot positions the pointer to the center, and the patient then uses their arm to go to each one of the lighted targets that light up in yellow. After the activity is started, the patient moves the robot arm to each of the targets for 5 rotations around the circle, which gives us a total of 80 repetitions. This is done without robotic assistance. This setup is used to further break down the area of the circle where deficits might be present so that the therapist can use the information to determine limitations into specific directions of movement. For example, this patient is able to move into all of the directions around the circle, but if you look more closely, you can actually see the overall shape is appropriate. But note the increased lack of coordination into external rotation as evidenced by the wider arm of the graphic into the northeast and east directions, which correspond to external rotation and external rotation combined out of synergy pattern into shoulder flexion and elbow extension. Even though the graphic appears pretty normal in shape, this patient has a significant deficit noted by the metric for movement duration. So the expected performance for movement duration would be 1.4 seconds. In this patient's case, we can see that they are showing an 8.5 second movement from one point to another. Thus, we have some kind of a metric to work on for therapy. The next part of the report is the stability assessment. This examines the patient's ability to maintain a position in space. In this case, the center point of the circle. This is against a force that's being applied by the robot into specific directions that correspond to muscle groups. In our patient's report, we can see that when the patient has a limitation in a specific direction, the device is able to move the patient's arm, and the graphic shows up as that star shape. So at initial evaluation for this patient, they weren't able to stabilize against the force, so that star shape shows up. What this means is the robot was generally able to push all the way to each target, a sign of either muscle weakness or a lack of coordination. We also can measure through the metrics the average distance that the individual was able to stabilize against, giving us an idea of whether the person was able to stop the force at all. We can also break that distance down by direction, which can correspond to muscle groups being able to perform this activity. In addition, we show the maximum force that the individual was able to stabilize against into each one of those directions, and the peak force applied to the arm averaged over all of the direction, which gives us what the device calls the overall isometric hold force, which again is a measure of isometric strength. The final section of the evaluation is a strength assessment, in which the patient pushes against a force generated by the robot that is similar to pushing against a TheraBand into each of the directions that correspond to muscle groups. As seen in this report, the patient's deficits in strength can be graphically represented to give visual feedback to the patient and break down the movement into directions related to straight plane and combined movement patterns that represent coordination between muscle groups. In this patient's case, we can see a consistent lack of strength out of flexor synergy pattern that could indicate true strength loss or increased tone interfering with the patient's ability to move in that direction. We can also see a good ability to generate force into shoulder internal rotation, but limited into external rotation as shown by the deviated line toward flexion that may correlate to flexor synergy tone as well. Here again, we show the distance from the center point that the individual was able to push against a force into each direction. This is equal to the maximum distance that the patient was able to go around the circle. We also have forces measured in each direction as well so that we can delineate which direction the patient was strongest. The peak force, again, is measured here as well, giving us an indication of the patient's overall strength. So once the therapist analyzes the evaluation, he or she can then determine the best course of action for therapy using the InMotion system. Because the reporting is instantaneous, this can be done within the first session. And the therapist can use the report on the screen as part of the education of the patient as to the deficits present, depending upon the patient's cognitive status. Some of the options for arm therapy are listed here. The device allows for a wide range of activities, including movement focused on improving range of motion, strength, coordination, directional movement to isolate motor directions and deficits, and 2 modes of increasing focus and motor coordination called error augmentation and curl perturbation. One of the other nice features of this system is the fact that there are graphical images included in the system under the graphical A and B categories. The A category is used mostly for adults, and the B category can be used for children. The images are depicting toys. And so what these images allow us to do is to expand the motor component of this into a cognitive activity as well. There are other additional activities that are also related to cognition. For this patient, the above protocol was used to increase motor control and mobility of the arm into all planes of movement. The average time for treatment can be as short as 30 minutes, with achievement of anywhere from 400 to 600 repetitions as recommended in the neuroplasticity research. Of course, we know that the current norm for traditional treatment is an average of 30 to 45 repetitions in a 50-minute session. And this patient was able to achieve approximately 600 repetitions within a 30-minute session. With each treatment session, there is also a report generated that will allow the therapist to evaluate performance during the treatment session and analyze performance over the course of treatment in comparing one day's report with another day's report. On this specific report, we can see there are 2 what we call active movement tests. These are done without robot assistance, very similar to the evaluation point-to-point activity. This one is done at the beginning of treatment and one is done at the end of treatment. In cases where graphical progress isn't obvious, as in this patient's case, the metrics and percent change can show progress itself. So in this patient's case, if we look at the measurement for smoothness, we note that if you compare the patient to themselves, as we do with the percent change, this patient, even though the graphics don't look very different, did have an 18% improvement in smoothness and a 64% improvement in target accuracy. The treatment protocol shows up on the report as well. This assists us with being able to communicate what we did with the patient and either have another therapist perform the same activity or repeat it ourselves so that we know exactly what we have done. After 6 sessions of treatment for this patient, using both robotics and traditional techniques over a period of 13 days, the team was able to determine that the patient was ready for discharge to either home or another level of care. So we want to make sure that we get a recording of the patient's final evaluation status so that we can compare how much progress this patient made during their stay. On the circle report, the evaluation report compares the initial evaluation to the discharge evaluation. It can compare up to 3 sessions in one report, showing the changes both graphically and in the same metrics measured on the initial evaluation. Here, the circle report shows the following. We note that there's a significant improvement in coordination and in active range of motion as reflected by the change from the flattened area of the circle to an actual diagram that looks like a circle. So if you look at the graphic on the right, you can see that that's easily identified as a circle. The one on the left, not so much. This can be an improvement in either coordination or in range of motion, or a combination of both. In this case, we also see an improvement in the shape and the size of the graphic and in the metric numbers that correspond to it. So here we have an expected performance at the end of treatment for circle symmetry of 98%, which is pretty good. On this report as well, we can see graphical improvements shown by the greater circular shape and the narrowing of the area of the graphic. This indicates usually an improvement in coordination. We also see improvements in performance reflected in these metrics. So we see in circle size, here this patient improved from 24% of expected performance to 44% of expected performance. We also have a recording of the number of days since the initial evaluation was performed, indicating the amount of time taken to achieve the improvement that is seen in the graphics. On this patient's point-to-point report, the general shape of the star is the same, but on closer inspection, some differences are noted. The graphic is larger in the final report and more defined, meaning more consistent. These changes are more pronounced in the metrics changes seen as well. So we note at the end of the treatment session, there is an improvement in range of motion into all quadrants, particularly those away from the patient. So if you see in the first graphic, we don't actually reach the target, but the patient does completely reach the target in the second graphic. This can be a definition of coordination as well by the increase in the consistency of the lines, and then also an improvement in aim because the lines are straighter, which you can see in the graphic itself. When you look at the aim measurements in the metrics, we see an improvement from 1.07 centimeters away from the target at the end point to 0.73 centimeters, and this reflects a 32% improvement from start to finish. We can also see the comparison not only to the patients or to healthy individuals, but we also see here a percent change where we are comparing this individual's performance at the beginning to the end. In the point-to-point as well, after a period of therapy is performed, we do this reassessment, which shows an improvement into range of motion into the upper quadrants. This could reflect some improvement and ability to move out of flexor synergy. It could also reflect possible reduction in tone of the flexor muscles at the elbow, or a combination of both of those factors. When we look at target accuracy, it improves as shown by the larger graphic and a smaller number away from the target. So in this case, the patient improves from 7.88 centimeters to 0.88 centimeters. And we can see that reflected in the expected performance numbers going from 0% to 99% as well. In our stability report, a stark change is noted with the concentration of the movement around the center point of the circle. Remember, on the initial evaluation, this patient was unable to stabilize against a force. Well, we can now see that there's significant improvement in stabilization against that force into all planes of motion, as evidenced by the shortening of the distance around the circle. This is also reflected in the metrics down below, and it's done by direction, just as it is in the initial evaluation. And then we also have a comparison here to healthy individuals, in this case, a 64% of expected performance. On this report as well, we can see significantly improved ability to resist against motion into all of the different planes. Again, that centering of the concentration around the center of the circle. A comparison to the patient's current performance is shown by the percent change here at 45%. And again, we can still distinguish muscle weakness by direction, even though this patient was able to achieve 100% of the expected performance. On the resistance report section, a change in the patient's strength is also noted. This is evidenced by the increased size of the star shape, but also by the improvement in the overall star shape altogether. Greater distance to the outer targets is reflective of either increased strength or decreased flexor synergy. Greater control against resistance is exemplified by the thinning of the line, indicating a single, smooth force generation, except you can see with the little squiggles at the end of these lines, this indicates a little bit of decreased strength at the end of motion. We can also see a demonstration of continued limitation and coordination of external rotation with elbow extension out of synergy pattern, as evidenced by the thickening of the line going into the northeast position. And again, we have a comparison of this individual to healthy individuals in the expected performance. The overall strength level is determined by averaging all of these over into each direction, and that gives us our overall strength, in this case of 27 newtons of force. We can compare this individual against themselves, giving us our percent change of 103% in this case. And then also, please note that you can, even though this person has reached 100% of expected performance, we can break down that movement pattern by direction. So we've talked about how the reporting system gives the patient and clinician visual feedback and how it helps to drive therapy. Now let's hear from the clinicians themselves about how the reporting system helps them make sense of what they're seeing in the graphics and the metrics. First, we'll see a short video of patients and clinicians in action, followed by a question and answer presentation with Sue Bodziak from Tallahassee Memorial, who you will see on this video.
Being the 7th largest hospital in the state of Florida, Tallahassee Memorial serves the lifespan of all patients, from the NICU from birth all the way through end of life. One of the areas that we really focus on are outpatient services, such as neurological rehab.
We have a really great team, and we're pretty heavy in NDT techniques and lots of weight bearing, complementary e-stim when it's appropriate to help reactivate some muscle groups or bring more attention to an affected side.
We schedule anywhere from 1,500 to 1,600 patient visits every month.
I was so excited when we got the robotic arm because it meant we had an addition and enhancement to what we're already doing.
The robot has been highly utilized since arriving here just a few months ago. At first we thought it would just be our stroke survivors that would be using it, but I would say it's a rare day that I can come into the room where the robot is and it's not in use by a patient.
One of the things that the robotic arm does is it gives the patient repetition of movement, which is really difficult for a therapist to do 400 movements of an arm. So we're able with the arm to allow them to get 100, 300, 400 movements in one session without them being overly fatigued and of course the therapist being overly fatigued.
We'll spend about half of their treatment time using the robotic arm, and then we'll spend the other half of their treatment time applying that movement that we just worked with on the robotic arm. So we'll move from that into weight bearing, or we'll move from that into functional activities.
It's repetition, repetition, repetition to get muscles to work, to get the arm to move again. And this carries over with their driving. It's carrying over with them even driving their electric wheelchair. It's carrying over with their feeding. It's carrying over with all the functional activities that we do.
Some of the features for the data that we can gather allow us to print out in graphical format that you can attach with your notes, and doesn't take a whole lot of advanced skill or advanced medical knowledge to read. You're able to look at the circle graph and you're able to tell hey, the circle's more rounded on this side. It looks like they're reaching further.
And there's nothing like a patient being able to see progress on a piece of paper. And looking at that screen and seeing where they were and where they are, it proves their progress. And so the biofeedback is an incredible positive component of the robotic arm system. Our patients realize fantastic outcomes through this clinic. And what I'm seeing in our patients is hope.
They told me I would never move anything, not even my neck. And as you can see, I'm moving my neck, I'm moving my hand, I can shrug my shoulders. So I mean, this machine is just giving me hope, basically.
I would like to now introduce Kate Edel from Bionic Labs and Sue Bodziak from Tallahassee Memorial to discuss use of the reporting and Sue's experience, as you could see on the video that we just showed.
Great, Sheree, thank you so much. Now we'll add our world famous video star onto the screen to add to the conversation. And again, please don't hesitate to ask questions using that Q&A function. You'll see us now start our videos and unmute ourselves. Hi, Sue. How are you? Thank you so much for joining us today. Just to start, can you tell us a little more about yourself, your clinical background, and then your facility and the patient populations that you treat?
Sure. So, like I said, my name is Sue. I was in the video. So I work in the outpatient neurological unit at Tallahassee Memorial. I've worked here for 4 years now. Like I said earlier, or Kate had said earlier, I got some continuing education in LSVT, so I treat Parkinson's disease. We also have a collaborative care unit for Parkinson's disease that I'm with. Also, I treat some driving, so we do cognitive skills called Drive Able, which is a test for driving skills. Otherwise, we treat all neurological injuries. I mostly have stroke on my caseload, spinal cord injuries, Parkinson's, MS. And currently I'm studying for lymphedema therapy. I'll be certified in July. And at our clinic, we are attached to a inpatient clinic as well. So sometimes for our robotic arm, we'll have people come from the inpatient to use the robotic arm as well in our clinic, which is really nice. We have occupational therapy, we have physical therapy, speech therapy, we have a social worker on staff for counseling. I work with two other occupational therapists and a CODA. And when it comes to the robotic arm, we kind of split up our time with the robotic arm because we do have many patients wanting to use it since we are neurologically based, so it's very appropriate for our clinic. So we kind of split up the time with the robot, 30-minute sessions. And so we kind of have a sign up for that since we have inpatient as well coming to use the robotic arm, but it has been a great addition to our facility.
That's great. Sounds like you're not busy at all. And sounds like you need more robots, which I can happily help you out with after the call. So I know we've got some great questions that we've previously had submitted, and I know you have quite a few patient examples to help us with this. Before we jump into those though, can you tell us how you use the eval portion of the device to determine specific deficits demonstrated by your patients?
Absolutely. So I really like to use the evaluation tool first off, just to do the passive assist on the 10 centimeter screen or the 14 centimeter screen. I do both just to see how much range they actually have and what will they be motivated to do. So the 10 centimeter screen is a little smaller, and then the 14 centimeter screen is a little bit bigger. So we get to see how much actual movement they do have. I get to see their strength, their coordination, but it also really determines their endurance. So even if they're having a hard time with the evaluation tool, doing all the repetitions, you can easily modify it and just have them do less repetitions, and you'll still get a really good, thorough report, which is so important. But I'll use the evaluation tool then to decide what protocols to do with the patient, just depending on how they do. Do they have dyskinesia? Well, I'd use the error augmentation
to kind of make their movement look really bigger than it is, so they're able to focus on it. I like to look at their visual motor skills too with it. Do I want to use it for mostly strength? Do I want to use it just for coordination or trying to get some more movement with their range? So it's just a really good way to determine how we're going to use it, and then what skills do I want to do outside of that? What ADLs do I want to work on with those motions or any therapeutic activity? So it gives a really good baseline.
Yeah, I love your example of finding that just right challenge where I can modify it or grade the activity, even the evaluation. And I'll ask Sheree to jump in here and give a little more detail about the difference between those two circles that you're referencing. Those are really great points. Sheree, do you want to jump on?
Sure. So in the setup of the device, there are two different size circles. One is a 10 centimeter radius. The other is a 14 centimeter radius. And what this allows us to do is to tailor the program specifically to a patient. So if somebody is struggling with achieving the 14 centimeters, one of the things that we find is that we know from research in particular that if you can get somebody to an 80% success rate, they actually learn faster. And so one of the things that we like to be able to do is to not only challenge our patients, but also help them succeed. Because a lot of times with stroke in particular, people don't think that their arm is moving because it doesn't move against gravity. Well, if you take gravity out of the picture, they actually start to see that they have a lot more movement than they thought. And so by doing that, we give the person some success. And then we challenge them. And we can challenge them in two different ways. We can either change the size of the circle to the larger one, or we can even set it up so that you're only doing the northern hemisphere. And the person is actually only doing motions into that outer range of motion.
Great. Thank you for that insight there. And Sue, I also liked your example about how you choose protocols and interventions based on what you see in the evaluation, and your example of the air augmentation is a perfect one. But I also appreciated your point about, yeah, we'll do the device, we'll get all these repetitions and work on the robot, and then take it to like the ADL kitchen or to the mat and use some other functional tasks. That's such a great point. And I know therapists often are like, well, is this the only thing I do, or that dosage? And we'll get to that later, but thank you for bringing up those points. Now let's get some of these patient examples I think are so powerful and valuable to understand the device. Our next question is related to, if you can describe a patient scenario that shows how the InMotion reporting system has impacted your treatment and that patient's progress. So tell us about this person.
So this patient, his name is Michael. He is a 14-year-old. He had a stroke caused by a gunshot wound to his left eye when he was 12 years old. So he came to me for outpatient therapy just recently in February, and he presented with left hemiparesis, spasticity, and clonus. He started using the robot right off the bat in February, and you can see his evaluation there on the left side of the screen. We also would use the screen because he has a glass eye in his left eye. So he is using his right eye to compensate. So we would put the screen to the left side so he was able to visually scan to compensate for that vision loss. That was also a really great aspect of the robot. But you can see that from February into the next 3 months that we did it, he was able to improve by a huge significance. And he was very competitive with his scores, and his coordination had improved out of the most, I think. But this was a really fun thing for him to do. Every time he would come in, he was really excited to use the robot. Since he is a kid, he kind of thought of it as like a video game, but it was very visually motivating for him to use this.
Oh, absolutely. I don't love for that patient, but I love that even though he had a visual impairment, he was still able to use a device that has a monitor, has a screen. So there are still ways that we could modify for him to be able to have that success. And I think even if I had never seen this device, never seen this reporting system. I didn't know what any of these words or metrics meant. I can look at the image on the left and then the image on the right and see, okay, that circle is much more defined. And that, I mean, the round dynamic, and I'll let Sheree jump in here in a second, but very clearly there's improvement here. Sheree, do you want to tell us what sticks out the most to you in these images and metrics?
Sure. So if you didn't know this patient, which I don't, I've never seen him, you could still actually look at this report and see that his motion wasn't necessarily horribly affected, but what was affected was strength. So, and how do I know this? Well, the way that I know this is if I look at the star pattern and I compare how big of a star he has at the beginning versus how big of a star he has at the end, they're pretty much the same. But what he doesn't have is coordination to keep that line very straight. And then in the circle pattern, you notice that it's kind of an elliptical shape on the left, but it's still pretty large. So he hasn't lost range, but he's actually lost the coordination to make a circle. If you look at the bottom, this is where it's the most dramatic. So if you look at the strength plot, which is the one to the bottom right, you can actually see that he goes from a scribbly motion to a perfect star, which means this guy got a lot better. And that just means that Sue has a lot more to work with.
Yes.
Exactly. I mean, I'm noticing he couldn't even go against the force on that one target, and then he almost reached the exact point. Like you said, 3 months later. That's great. Okay, well, let's move on. I think you have another patient example for our next question, which is, what has been your patients' responses to using the InMotion ARM? How has the reporting system helped you communicate with them about their deficits?
So patients, like I said, they get really excited because they get immediate scores. I think that's what is so motivating about the robot, is getting those immediate scores and wanting to be able to improve them. And like I said, it's so visually appealing that you don't have to know how to read the metrics. You're just able to look at it. And I think the patients really appreciate that.
Absolutely. Yeah, tell us a little bit about this patient.
Yeah, like I said, he is a kid, so he gets really excited thinking this is kind of like a video game. So Kim, yes.
Yeah. I'm sorry, I think the screen just changed for you.
Sorry about that.
That's okay.
Right, so Kim, yes. So this patient was actually in the robotic video. She was the spinal cord injury. She was a C4 injury, complete spinal cord. She was had a car accident. Her 3-month-old baby was also in the car. The car had flipped, but the baby was okay, no scratch. And she came out, like I said, with a C4 injury. The headrest on the car seat had broke her spinal cord. So she came to me a few months after her spinal cord injury, and she had no movement at all. She was moving her head, and that was it. The doctors had told her that she would not be able to move anything for the rest of her life. Obviously, we want to try to improve some movement. So we kind of started with her shoulders, trying to get some shoulder depression, elevation, get the scapular retraction motion, because she had subluxations that were causing her a lot of pain. Well, by this time, she started to be able to move more. She ended up being able to move her left arm. So this is when we decided, let's try using the robotic arm with her. So we started using the robotic arm, and she's able to get some movement, which was really exciting. So this ended up being that we started to make more goals for her left arm then, and we wanted her to be able to get enough movement where she could use the joystick on her electric wheelchair to be able to drive it. And also feeding goals, we were able to get her set up with feeding. And she eventually she had a Medicaid insurance, and she was running out of visits. So this patient is really exciting. I ended up writing a pretty extensive report to her insurance company trying to get her more visits. And I was able to print out these forms, and I wrote a report with them and sent them to her insurance company. And she was able to get 4 more visits, which wasn't a lot, but it was something. So it was exciting to see how these tools can actually help you to get more visits with your patient. As you see on the graphs, so her smoothness of movement had improved 81% of the expected performance on the robot. And this is so important for her functional goal of feeding herself. And the 81% reflected that goal. So we were able to do min assist and set up, we're positioning the plate as you saw in the video, and a universal cuff for her to be able to feed herself. And then the lower reach error and the path error was also necessary for her feeding goal. So her 24% reach error after 24 sessions reflected a significant improvement towards her goal of 2% carryover with the setup of her left hand on the joystick to be independent with driving her electric wheelchair. And this obviously helps ease her caregivers for her to be more independent. So this is a really great example of how you can use the documentation to get more visits as well.
Oh, absolutely. I mean, based on her diagnosis and prognosis, but the physicians were telling her it's shocking that we see movement at all, and let alone the fact that you were able to relate each metric back to a specific functional task. Like, we needed this for feeding specifically, is so impressive. Sheree, I'll let you jump in and tell us your thoughts based on this report here. And then Sue, if you have, I mean, I know this was your patient specifically, what was her reaction and how did you get her to respond to seeing this on the screen?
So she was really funny, actually, because she became very possessive over the robot. Everyone would laugh about it because she would come to therapy, and if someone else was on the robot, she would say, "Why is that person on my robot?" So I think she really, really enjoyed it because she was able to see her movement. She doesn't have a lot of movement, but she does have some, and to her that meant everything. So for her to visually able to see that she can just make movement on the screen, even though it's not a perfect circle or a star shape that she's expecting, she still just was happy to be able to move. And then when you explain to her the results, it's really motivating as well. And also the carryover of her feeding herself and driving her wheelchair.
Yeah. That's just another level of independence for someone who was told they would not be able to do anything. That's amazing. Right. Sheree, I'll let you jump in now.
Absolutely. So one of the nice things that you see here is how even in a patient who only has movement in one quadrant, they can still utilize the device. And in her case, you'll notice that the weakness and the synergy pattern is affecting her ability to even get to the center point. So the cool thing for her is the fact that in the progress report, in the daily therapy report on the right-hand side of the screen, you can now see that she's starting from the center point, which is an accomplishment in and of itself. In that she's now able to position her arm and start from that point. But not only does she achieve that, but in that flexor pattern, she also is able to break out of that enough that on the northwest side, she's actually able to hit target, which that's a huge gain as well. That's the difference between being able or unable to reach a plate and now being able to reach it. And that's huge, as Sue mentioned. I mean, that for her, that was a big success.
Great points. Yeah, her goals specifically of feeding and driving her wheelchair independently. That's great. Okay, I think that now we have even one more patient example for this next question. And it asks if you could explain how you incorporate the InMotion ARM into your clinical practice and talk about specific diagnostic groups that you tend to use the device with.
Okay. So obviously we use a lot on stroke, spinal cord, Parkinson's disease, even MS. Really, I've used it probably with every neurological diagnosis. Also, I use it a lot with, like I said earlier, I do an assessment called Drive Able, which is a cognitive assessment for driving. So it's a computer-based test, but there are similar visual motor things that we do on the Drive Able that are similar to the robotic arm. So especially for spatial judgment. So I will even work with people to try to get that spatial judgment a little bit better for them to be able to do the drive able testing. So I even use it for that. I've even used it for even lower spinal cord injuries that do have good upper body and upper extremity use, but I use it for their trunk control, using dynamic tall kneeling skills and having them on the floor on a mat and using the robotic arm, the stabilization resistance to kind of challenge their balance. So I've even used it that way. So there's so many different ways that you can use it.
Yeah. Do you want to tell us a little bit about this next patient?
Yes. And so this patient, JT, he had a stroke. He's a 70-year-old. He had his left non-dominant side hemiparesis. So he is an avid fisher and hunter. He raises bird dogs. I think he has 12 dogs, and he hunts quail. So his main goals were obviously to get back to hunting and to take care of his dogs. He had continued therapy for about over a year. So we first did the robotic arm in 2019. And you can see on the left side, that is his first evaluation. And then a year later, how much he had improved. So it was a really big jump in his improvement, but it did take a little bit longer, maybe due to his age and the severity of his stroke. But even after a year, it shows, this is really good data just to show how much improvement you can actually get. And he is now hunting and he's taking care of his dogs, all with adaptive equipment. But the robotic arm definitely helped his mobility with that.
Wow. Now, I know you mentioned that all of your patients' therapists are fighting over the device. Can you tell us how you kind of manage that in terms of dosage, or how often your patients are using it? Is it a time-based? Is it a number of repetitions?
So the way we've been doing it at the clinic is 30 minutes. So we have an entire hour with a patient, which is really nice. And so we, like I said, there are 2 other therapists that I work with. So we have come up with a little protocol of just doing 30-minute sessions, and we have like a little sign up. So we know when our patient's coming, and we'll sign up for the first 30 minutes of the session or the last 30 minutes of the session. I prefer having the first 30 minutes of the session. I really love doing the robotic arm to get their arm warmed up and get them motivated before we do an ADL or do a therapeutic activity.
Okay. Sheree, do you have any comments on other strategies for dosage, or maybe what other settings might use?
Sure. So in the acute inpatient rehab world, many times there are so many things that people have to work on that getting enough time on the robot can be difficult because, again, as we all know, there's pressure on everybody to get people out of the hospital as fast as possible. So we do have clinics that tend to use it for 20, 30 minutes at a time and then follow it with an activity, particularly. And Sue, I want to tell you, you have the perfect video for this. In your video, it literally shows exactly how to do this. You put your patient on the device, you warm them up, and this acts as your therapeutic exercise or your neuro-re-ed techniques. And you can get hands-on patient while you're working with them. The device does not interfere with that. And then get them on a mat, get them in the kitchen, get them someplace and work that body part, work that arm, make them actually do what you were just practicing. And it's beautiful to see it. And both of the activities that you chose for those 2 patients were perfect.
Yeah, we couldn't have asked for better patient examples. These are fantastic. And that's a question we get all the time. Sheree mentioned therapists asking, is this replacing me? You know, is this taking away from my job? And absolutely no, this is a tool. We need your therapeutic use of self, your clinical judgment to decide what's appropriate and to then take it into the functional world. So thank you so much for these great patient examples. Now I think we can address some of the live Q&A. We still got some time, so we'll jump to some questions that have come in. The first one here I'm going to address for you, Sue, and this comes from Judy. Hi, Judy. How are you? I miss you and your team. And she's asking, do you ever have the patient do mental imagery during physical rest breaks while using the arm robot?
Huh.
Great question.
That is a really great idea. No, I have never done that, honestly. But now I really want to. That gives me a really good idea.
Yeah,
No,
functional therapeutic rest break. Yeah, yeah. Sheree, have you seen that?
I haven't, but I'm on board with Sue. This sounds like something we need to be encouraging people to do. Congratulations to giving us a new idea.
Yeah, I'm writing it down.
Yeah. Judy, if you've done this with your patients, either ask another question or send me an email, and I'd love to talk more about that. That's a great point here. The next one is going to go to both of you, but Sue, I'll let you address it first. He says, I'll be honest, documenting is the bane of my existence as a therapist. How do you take the data from the evaluation and those daily reports and then translate it into your documentation?
So it is really easy. It sounds like it could be hard just looking at the metrics and things, but it really is simple. You can take the percentages, they're right on there, and document them. I like to document how many reps the patient had done. That way I can indicate their endurance skills, and also I'll document how many times did they start or did they start the movement. So that's really important as well. I also I print out the evaluation reports, and I will attach them either to the insurance, or we can actually upload them into our system and put them with the documentation as well. So really, it's really simple once you get the hang of it.
Yeah, and I'll let Sheree address that too. But your example of taking Kim's report and submitting it to insurance is obvious that it does work, and it's very easy. But Sheree, I know that we've got this question before, so I'll let you tell us your thoughts on the documentation and what they should do.
Yeah, this is actually one of the common questions that we get, only because everybody wants to be able to report exactly what they did. I mean, that's how we get paid, but it's also how we show improvement with patients. And if you can't do that, that becomes a bit of a problem. The nice thing about the device is the fact that it has two different ways that you can actually pull reports off of it. But the big thing is we always want to make sure that we tell everybody, before you do either one of these, check with your IT department and make sure that it's permitted in your facility. We don't want to be getting anybody in trouble. So the big thing here is you can print them out, and then those reports can easily be scanned in to the medical record pretty directly. It also makes it really easy to do what Sue did and send them off to an insurance company to say, hey, this is the improvement this patient is getting. We think that it's worth your money to actually improve this patient even further, which of course Sue was successful with, which we absolutely are quite happy. The other thing that you can do is the device does have a USB port in the back of it. And so you can just download to a USB drive and then download that into your own EMR. So your own medical record system. Now, again, the caveat to this one is always check with your IT department before you download anything onto a USB, and then also get permission to interface with the EMR within your facility.
Okay, good addition there. We don't want to get anyone in trouble. All right, I think we have time for maybe one more question here. Sue, I will address this to you first. What is your billing process when using the device? Is it all out-of-pocket payments, or can you use regular therapy billing codes? Any creative revenue strategies?
So I haven't had any out-of-pocket. Insurance has covered it because it is evidence-based. And I always document neuromuscular or therapeutic activity, and I have no problems with billing at all.
Okay, Sheree, anything to add there?
Yeah, so we do know that there are a couple of facilities that are either looking at or actually have created some different protocols for this. So there's one facility that I think we spoke with that is looking at creating a robotics lab kind of a thing where people can pay out of pocket, even though they're in an inpatient rehab stay. They're running it through a quote unquote non-skilled individual. This is their rehab tech. So it's not somebody who is going to be changing protocols or modifying anything. But the secret we know to improvement with motion is repetition, repetition, repetition. And how do we get that if we have limited time? The answer is we get creative. And so in this case, their way of getting creative was to bring in or to have additional after hours time available on the robotics device that someone who is not getting paid large sums of money could actually provide that service to the patients. Another way of doing it is through rec therapy potentially. So it is possible that a rec therapist might decide, might get trained along with the PTs and OTs, and you might do it that way and do it as a cash service. So there's lots of different things that you can do. I can tell you that we've not had any reports of anybody not getting paid for using it as regular therapy.
Very true. Great. Well, thank you both so much. Thank you to our wonderful presenters, Sheree and Sue, and then all of our attendees. We really appreciate it. This just about wraps us up. If your question was not addressed, we will reach out to you via email. Otherwise, you can contact our team. My email is kedell@bioniclabs.com, or you can check us out at our website, bioniclabs.com, as you see on the screen. Thank you again, and I hope everyone has a great holiday weekend.
Thank you.
Sue, thanks so much. Wonderful having you with us.
Thank you. I appreciate being here.
Great, thanks.